So hi Jim, thanks for joining me, and thanks for joining us to talk about inclusive health. It's great to meet you. Can you tell me a bit about yourself and introduce yourself, and maybe tell me what inspired you to do this area of work, really?
Yeah, good morning, Russ. Good morning, everyone. Well, I don't know what time it is you're watching this, but hello anyway. I'm Jim. I'm 54 years old. I live in North London. My favourite colour is purple, and I support West Ham. I like punk, indie and ska music. So the reason I tell you that is not just because I think you might want to know, you probably don't, but that's okay. The thing is, we know so much about the people that we support, and yet they know very little about us as health professionals, and that's wrong in my view. So that's why I always share a little bit about me, so people can pick up on who I am rather than what I'm necessarily doing with and for them. It reduces the barrier. It makes me seem human as well to them. And of course, we're all human. Doesn't matter who you are, whatever your situation. We all have abilities, skills and talents. So who am I? Well, I've told you I'm Jim. Jim Blair. I'm a learning disability nurse. I've been a learning disability nurse for the best part of 30 years. Well, that's how long I've worked in learning disabilities. And you know what? It's absolutely fabulous. It's a joy to work with people with learning disabilities and their families who are the experts, not health professionals, is just absolutely brilliant. And I love every day that I work. I can't say I enjoy every element of every bit of the work I do. That would be a lie, but I do enjoy the vast majority of it. So I've worked as a consultant nurse for people with learning disabilities in two large hospitals in London, one St George's Hospital in Tooting and one Great Ormond Street in the centre of London. I've done lots of other things, and if you're interested, you can find out. And if not, don't worry.
I took my daughter to see a healthcare professional. What sort of things would you expect to see to make it an inclusive experience?
Well, I think the first thing is if you want to know whether the health professional is genuinely engaged with you and on your side, and that being your child and the parents or whoever's going with them, is the fact that the interaction should be first towards the person. So the person with the learning disability, the person with Down syndrome, rather than the family. And that's not to say that the family are irrelevant. Far from it. They're essential. But it's really important to focus in on the person that you're going to be engaging with. Even if they don't want to engage with you or can't engage with you for whatever reason for a very long time. The point is, I will always introduce myself to them first, because that's the most important person. They're the most important person in the room. I'll also pick up on something, a colour that they're wearing. For example, oh, I like your colour, it's red. Oh, my favourite colour is purple. Or we'll pick up and we'll have a little conversation, if we can, verbally or non-verbally. Why is that important? Because immediately, and Russ, you may or may not agree with me, and other parents as well, it automatically tells the parents that the person engaging is engaging with a person who's right at the centre of it. Once I've done that engagement, I'll go, and who are these people with you? Oh, they're mum and dad, are they? Oh, hello, mum and dad. But they can't just be called mum and dad because they're not my mum and dad. So what are their names? And then that often brings a little chuckle, a little bit of a laugh, which again lightens the mood, which means that actually all people in the room are realizing that this is a human interaction rather than something that's done to someone. It's done with, and that's the important thing. It's done with somebody and for them.
I understand that you set up a self-advocate group. You've been involved in self-advocacy and self-advocate groups, and a self-advocate health group you've set up. Am I correct in asking that?
Yeah. So what I've done is at both of the two hospitals I mentioned earlier, I set up a group called Learning Disability, Our Health, Our Hospital. And the reason for that is that personally, I'm held accountable to people with learning disabilities first, and then their families. And then third, it is to the directors of the hospital and the rest of the health professions. And that's not to say anybody's better than anybody else, but primarily I'm here to serve those with the learning disabilities. So I set up the panel to hold me to account, and that was made up of the majority were people with a learning disability and family members, and the co-chairs were a person with a learning disability and a parent. And this worked really, really well, because what you're looking at there is a balance of power shift where they look at what is required. They are informed and engaged and involved in making the solutions happen. So training and educating alongside me, looking at what needs to happen, taking accountability for what's going on in the training, and really engaging how the process and things can be improved environmentally and so forth within the hospital. But what I think needs to happen, and this is maybe what you're talking about more, is that I think nationally and internationally, if you really want to get the lives of people with learning disabilities better, and if we really want to stop people dying on average 20 to 25 years younger, certainly that's the UK data. If you want to stop that happening, there are solutions. It's about whether the will is there to make that happen. And one of the key things for that is to have 3 co-national directors for learning disability. 1, a person with a learning disability. 2, the second person being a parent, and the final 3rd person being a health professional or a professional of sorts. So that already means you've got a 2-1 split. So the balance of power has shifted already. Then you have a panel like the one I've just talked about in Learning Disability Our Health, Our Hospital, but this is on a national and it could be on an international scale as well. And they are made up of 51% people with learning disabilities, 34% family members, and the final and the least important, 15% health professionals and other professionals. So if you take that as being out of 10, you'd have 5 people with a learning disability, 3 family members, and 2 professionals. So it's an 8-to-2 split. You've shifted the balance of power in the right way. We need to move away from this model that it's service-led, it's caregiver organised, rather than those that experience the learning disability in their families and actually building from them their experience and expertise. And if we do that, what we then have is that panel would then be held accountable to looking at the service development, delivery of care, what's required, the professional education, the quality monitoring, improvement standards, how are they going to make things better, why are they going to make things better? And with accountability, and with responsibility comes accountability. And then what you've really got is a flourishing change, because you've got the very people who want to see the change and know what the solutions are right at the heart of that. Now, the other thing about this model is it could be used for anybody else. It could be used a focus on epilepsy, for example, on diabetes, or mental health, or dementia. It doesn't have to be just for learning disability, but this would work specifically for people with a learning disability, and then could be used as a model for many, many others. And that will improve, enhance, and save lives.
Another thing that you've mentioned previously, not in this particular meeting, but I'm aware of, is diagnostic overshadowing. Do you want to tell us a bit about that?
Yeah, definitely, Russ. I think diagnostic overshadowing is an absolutely important aspect of care. And it does mean what happens for many people with a learning disability, as we're talking about now, and people with Down syndrome. Obviously, though, they are people with a learning disability. What happens to many of those individuals, and everybody is different, of course, but what happens and common to each one is something called diagnostic overshadowing. And diagnostic overshadowing in its simple form really is being blinded by the disability and not looking beyond that. So it's a bit like looking at salt and not working out whether it's salt or sugar, because salt and sugar look the same. They don't taste the same. They're not the same. But just if you look at that, that's what you're seeing. And so you've got to refocus on the person, tune into their frequency, to their being, who they are. So I'll give you a quick example. So you already know I'm 54. I live in North London, and you can tell I wear glasses. But if I just go and smack my head against that wall there, do you think, oh, well, that's because he's 54, he wears glasses, and he lives in North London? No, you don't. But if it was another bloke called Jim who happened to have a learning disability, it must be the learning disability that's done that, rather than thinking as you would for me without a learning disability, thinking about, is there something going wrong in his mind, in his brain, organically going wrong? Is there something wrong with his eyes? Is there something wrong mentally or physically? What else is going on for him? Because that's very odd behavior. But it's when people focus just on the learning disability and don't really explore that fully. So in health settings, for example, they might look at someone's behavior change and they're coming into A&E and the person, they don't really see this as being different necessarily for how they are. They might just put it down to the learning disability rather than looking beyond that. People don't go around and aren't born injuring themselves, causing harm to others. They're all trying to, if somebody's doing that, they're trying to communicate something's going wrong. So behind every single behavior change, whether it's an increase in an existing one or it's a new one, always, always, always look for a physical health or mental health reason. This will improve people's lives but also it will save and increase the length of their life because people will pick up health issues quicker and earlier.
That's good. And one thing you often think about is why people don't do it more often, but that's a very good point.
Well, I think why they don't do it more often, I think, to be honest, Russ, a lot of it, and to everybody listening, is that it's about the confidence, not necessarily the competence, but it's the confidence. A lot of health professionals around the world have never really, within their training, come across people with learning disabilities or worked alongside them. So therefore, when they're treating them in the clinic, in the community, wherever they're seeing them, in the general practice, primary care setting, wherever it is, they often feel very anxious and very worried, and they don't want to get things wrong. And that automatically makes it wrong because something's going to go wrong if you're that anxious. Whereas if you give a little bit of yourself, and that's why I started this talk with the bit about who I am, because if you do that, you've already broken down those barriers. And if you get something wrong, that's okay. And also, I always do this, even if I've understood what somebody with learning disabilities told me, I'll always go just to check if I've understood it correctly. Now, that doesn't normally happen in a person with a learning disability's life, that someone without a learning disability is checking if they've got it right. Because the assumption is, generally across the world, that someone with a learning disability won't get it as right as often as someone without a learning disability. So already you've changed the balance of power, you're changing your interactions. And if we change how we communicate and engage with people on that first level, we make sure that every interaction is important, and you're demonstrating that you realize that everybody has worth, and every moment is important. And that is why we do that. But it's a way of making sure that somebody feels comfortable with who you are as a professional in front of them.
If you were in a conference or somewhere where somebody said, Jim, what's the one thing I could do tomorrow that's very small that would make a big difference? What would you advise them to do? What would you say?
Yeah, great question. I think just be yourself, be who you are, be relaxed, be calm, engage. But the primary message I would say is, again, think about all you see isn't all that there is. Even salt looks like sugar. So think beyond what is in front of you. Things I always do is I ask people at the beginning of the training to think about a time when they didn't understand something. How did it make them feel when they didn't understand that? What help or support did they need to understand the thing that they didn't understand? And how did they feel when they finally got what they didn't understand? So they understood what it was that they didn't know before. Thank you. I hope you have a good rest of your day.